CVPs. What is a CVP? It's a fancy drill that MOs use to scare students and interns. That's all, nothing else. That's literally all that it is. It's just a fancy drill. Okay. In days gone past, we would use CVPs to actually measure central venous pressure. That's why it was originally created. Now we use it for difficult IV access. We do it for repeated blood drawing. We do it for where we need multiple infusions. We do it for everything besides actually measuring the central venous pressure. Now, come to think of it, we have arterial lines, we have much more invasive BP curves or better BP curves. So there's a lot of things that it was developed for that we don't actually use it. But if you've got a minute, you go back, read about medical history, you'll actually see how I remember doing it as an intern. I don't know, you're a bit younger than me, not by much. I won't give you your age, but I don't know if they were still doing it when you started. They were, isn't it? So you should remember that tube used to put and used to measure. It was a whole weird thing, you know, and now everything's just arterial lines. So we don't really use it for that anymore. So there's quite a few indications for it and quite a few contraindications for it as well. So like I say, nowadays, the main indication for it is that we're struggling to get IV access. All right. We need to give certain drugs such as adrenaline, phenylephrine, things like that, you know. So so, you know, the nice thing to know when you're going to use it and things like that. And then, of course, there's some contraindications. So if there's sepsis over the site that you want to use, patient has a high possibility of an infection being introduced, you don't have sterile equipment, you know, there's a whole lot of things. We're not really going to concentrate on CVPs per se. Today, what we're going to concentrate on is, how do I put in a CVP and how does the ultrasound make my life easier? All right, that's the thing. So let's get into it and then we'll take it a bit further. So here's some of the indications, all right? So CVP monitoring, which basically you can cut off. We don't really use it for that. I haven't used it in the last 10 or 15 years, all right? Volume resuscitation, although CVP is not the best for volume resuscitation because technically speaking, it's actually not the fastest way to get fluids inside. People think it is, but it's not, okay? You have much better chances with the peripheral line. So you guys have seen the gray, the 16 gauge, all right? So your CVP is the equivalent of 1 green and 2 pinks. That's what you're getting, all right? So it's not that you can give it very fast, but you can give a lot at the same time, but not necessarily faster. So if you can get a gray and you're actually getting better flow, and if you can get an orange in the 14 gauge, a really big one, then you can get in a heck of a lot more. And if you're really fancy, you can use something called a rapid infusion catheter, all right? And if you guys want to see that, there's some lovely videos on it and that. So it's similar to a CVP, but it's basically done on a peripheral body part. So you introduce a pink gel coat, you pass a guide wire through, and it's got a dilator. So you dilate the vein, and you push in this massive gel coat that looks almost like a urinary catheter. And you can give like a liter of blood within 2 minutes. You can give fluid like within less than a minute. So that's used in centers that have it, you know, and it's brilliant. It's really something to see. So what I'm saying is the CVP at the moment for volume resuscitation, it's one of the better ones we have in our setting. If you go to most South African hospitals, you won't find rapid infusion catheters. You'll find them in 1 or 2 of the bigger ICUs where there's intensivists, people who can force the government to give them fancy stuff. But the rest of us, we don't have access to it, okay? Cardiac arrest. Why in cardiac arrest? Because quite simply, you don't have any flow to your peripheries. So it's much easier to access a central vein because they don't collapse completely, all right? Lack of peripheral access, okay? Infusion of hyperalimentation, all right? Infusion of concentrated solutions, placement of transvenous pacemaker, which we've gone through before, cardiac catheterization, pulmonary angiography, hemodialysis. So these are all the things that we use them for. But in the emergency department, 1, 2, 3. Those are the 3 most common reasons why we use them. Okay. Right. So who's put in a CVP before besides the MOs? Because I know they haven't done it. They just pretend they call them. No, I'm joking. Could you have done one? It's fun, isn't it? All right. So if you haven't done one, all right, we're just going to go through the procedure. So in other words, what does it do? Now, there's no sound on this video, so I'll be describing what they're doing. So the first thing in anything, you have to get your pack ready. There's a few different types of packs, but they all follow the same technique. It's called the Salginger technique. Now, even before we get into the video, it's a very simple premise. Basically, you need to access a vein that's not near the skin. So the way that you access it is with a needle. as we do with anything. Even when you're doing a peripheral IV line, you get in and you make sure there's blood coming out. So that's what we're doing with the CVP as well. But how do I make sure I'm in that vein? Because I can't physically see what's going on. So the way that I make sure is I pass a guide wire. And that guide wire, once it sits inside the vein, I'm assured that whatever I put over that guide wire will go into the vein. All right. Once I've got my guide wire in, I just need to make a space for the CVP. So I use a dilator. And there's a few ways. There's one with the incision. There's one without an incision. So I dilate, and then I pass my port in. All right. There's 3 sites that I can do it: femoral, subclavian, and internal jugular. All right. So those are the 3 sites. But that's the basic premise. So let's see how they do it. All right. So here's our patient, and our patient is going to get an internal jugular CVP. All right. Now, ideally, you would have given anesthetic. You would not have stripped away the skin and muscle, and then you would have a feel for the the pulsation. All right. So this is when you're doing it without ultrasound. Okay, that's how you go about. So at the moment, the doctor's feeling for the carotid pulsation. All right, and you would expect the vein to be lateral to that. Okay. So once you've got that, then you clean it with any alcohol-based solution. All right. Now remember, it's supposed to be a sterile procedure. Okay. Now this is your needle. Okay. So all that you're trying to do is that you're trying to access the point of the vein. All right. Now the actual insertion points, there you've withdrawn your blood, so you know that you are going to get it over there. All right. Okay, that's a bit of an odd one. All right. So again, they're just trying to access the vein, make sure that they're in the vein. Oh, the first time they were in the artery, that's why, sorry. Okay, so you make sure you're not getting arterial blood. Okay. Okay, they're really making sure they're in the vein. Looks like, and there's your guide wire. Right? So basically your guide wire now goes through, passes through the needle. So it just depends on what type of a set that you have. Now, when your guide wire is passing in, there shouldn't be any resistance, or very minimal resistance. If there's any sort of resistance, it's not going properly, you're not in. You may have gone too far, you may be too shallow, things like that. That's just a piece of advice, So that's just a skin incision to introduce the dilator, which I'm hoping you're going to do now and not draw more blood. Okay, there we go. So it is a dilator, all right? Oh no, they've just introduced the port, all right? Now the most important thing is not to lose the guide wire. So what they're doing is they're passing the wire back and pulling it out through the other end and then pushing in the CVP, all right? Now in our sets, there's just one extra step in that we have a physical dilator that also goes over the guide wire, all right? Now the reason why you don't want to lose the guide wire is not because the patient's going to die, but the patient has a potential to have major complications, all right? So this is what they're doing. They're just ensuring that they're flushing lines, they're making sure that the whole system is working properly. And then right at the end, you've got to fix the thing to make sure that it's in the correct place. So we've got fixators, specific fixators, or you can use the fixator that comes on this side to make sure the patient can't remove it. All right. Now, what I was saying was, yeah, so we've just got that extra step of a dilator just to make sure that we get into the skin and we make sure that our port is running. Okay, and we've got just a little extra fixator that comes on ours. It's called a butterfly fixator. So that also locks it in place to make sure that you don't come out. Now, the other thing is when you are doing it, you also want to make sure that your port isn't in the heart. So you just have to measure. All right. You do a quick assessment. You kind of figure out where your right atrium is going to be. So that's more or less at T4. And then you come up and you say, okay, I just need to go in about 10 centimeters. So you make sure you don't go in too far. All right, that's about it. Because as the things moving around, it's going to give you odd ECG readings, potential for sepsis, things like that. So you just have to be a bit careful. Okay, so that's how you do an internal jugular. So how do we do an ultrasound-guided access? Why would ultrasound be of benefit to us? Because as easy as that made it look, the truth be told, you get patients where it's not that easy. Some of your patients have short, fat necks, big thighs, unable to palpate their subclavians or their clavicles, things like that. So even though ultrasound is not used for the subclavian, it's only used for the internal jugular and the femoral, and even during resuscitations where you can't feel pulsations, you can't feel what's going on, the ultrasound gives you a visual guide as to what is going on. So you're doing the exact same procedure. The only next step or the only extra step is that I'm using the ultrasound to see the actual vein. That's it, nothing else. So that's what we're going to look at now, right? How do they do that?
Today's module is going to look at the use of bedside ultrasound for placement of central venous catheters, specifically the internal jugular vein in the neck. So the question is, why use ultrasound for central venous access, and why not just use the traditional landmark technique? Well, interestingly, multiple research studies now show a decreased number of puncture attempts are needed using ultrasound guidance, and there's also a lower complication rate, such as lowering the risk of pneumothorax and hematoma. The U.S. Agency for Healthcare Research, the AHRQ, recommends ultrasound guidance for central lines right up there in the top 10 patient safety practices. Ultrasound will allow precise determination of the anatomy of the vascular structures in the neck prior to a puncture attempt. Here's the middle triangle of the neck that serves as the standard approach for cannulation of the internal jugular vein. We see here the branches of the sternomastoid muscle, the sternal head medially, and the clavicular head laterally. Here we're putting our finger into the triangle of the neck, and this indentation between the muscle heads would be the standard approach for placement of the needle. We see here that the clavicle forms the inferior boundary of the middle triangle of the neck. Within the middle triangle of the neck run two very important vascular structures, and as per the textbook orientation of the carotid artery to the internal jugular vein, we see in the image here that the carotid artery should run medial to the internal jugular vein, which lies lateral to the artery. However, unfortunately, there's great variability in human anatomy, and many times the internal jugular vein can overlap the carotid artery, as shown in the drawing here. Notice the variation in location of the internal jugular vein to the carotid artery, and many times the internal jugular vein is located on top of the carotid artery, making it difficult to cannulate. Thus, it's important to look with ultrasound before cannulation attempts to avoid puncture to the carotid artery. Here's the high-frequency linear type array probe that we'll be using to best map out the internal jugular vein before puncture attempts. Notice the probe marker there to the side of the probe. Here are the orientations that we can place the high-frequency probe in relation to the internal jugular vein for vascular line placement. Here to the left, we see the short axis configuration with the probe perpendicular to the vessel, and notice that the vessel will appear on the ultrasound screen as a circle, as the vessel will be cut end on. To the right, we see the long axis configuration, and note the probe placed along the long axis course of the vessel. The vessel, therefore, on the screen will appear as a tubular structure, as shown here in the image to the right. Here's the high-frequency linear type array probe placed over the middle triangle of the neck, over the internal jugular vein and carotid artery. Now, I like to have the probe positioned in a side-to-side orientation with a marker dot oriented towards my left as I stand at the head of the bed. The reason for that is then the orientation of the probe marker will line up to the orientation of the screen indicator dot, which we see here is oriented towards the left on the ultrasound screen. Thus, the left side of the probe will orient directly to the left side of the screen, and this will allow us to orient ourselves as we place the needle underneath the patient's neck and cannulate the vein. Here's a typical appearance of the internal jugular vein and carotid artery in a short axis configuration, taken with a B mode or grayscale image. Note lateral here towards the left and medial to the right. Here we notice the internal jugular vein in a location more lateral and superficial to the carotid artery, which lies deeper and medial to the vein. We can see the depth markers to the side, and we note the internal jugular vein at about 1.5 centimeters depth. Now we can apply Doppler sonography to further differentiate the two structures, and here again we notice the internal jugular vein lying lateral and superficial to the carotid artery. We note the Doppler sonography steady pulsations of the internal jugular vein that vary with respiratory pattern, and we also see the carotid artery with the pulsations with each heartbeat differentiating the two structures. We can also press down with the probe to differentiate the two structures. The internal jugular vein should compress completely, while the more muscular outer walls of the carotid artery should keep it open with compression of the probe. Here's another video clip showing the internal jugular vein and carotid artery in a short axis configuration. Notice here that this internal jugular vein is much more distended than in the last patient. Here we see that the internal jugular vein is located more superficially at about 0.5 centimeters and that it overlaps the carotid artery medially. Highlighting the fact that there's great variability in the course of the internal jugular vein in relation to the carotid artery, even within the same patient, we're running the probe from a position high within the neck, in which the internal jugular vein is seen more laterally, to a position more inferiorly, in which the internal jugular vein comes to rest more medially on top of the carotid artery. Here's a different patient in which the internal jugular vein is seen smack on top of the carotid artery. Notice here we'll place Doppler flow to confirm the carotid artery, shown here deeper to the more superficial internal jugular vein. In this patient, it would be extremely difficult to cannulate the internal jugular vein without puncturing the carotid artery. best to attempt cannulation in another area of the body. One pearl that can be used to further distend the internal jugular vein and make it a better target for a cannulation attempt is to have the patient valsalva or hum. Notice here in the image to the left, the patient is bearing down, and notice that the internal jugular vein becomes much bigger as the patient pushes down. In the image to the right, note the relatively small caliber of the internal jugular vein. Notice that it's almost as big here as the carotid artery, but that it becomes much more distended as the patient bears down. Using the Valsalva technique can make it a much better target for placement of the large cannulation needle. Here's the high-frequency probe placed in a longitudinal or long-axis manner on the patient's neck. Notice here that it's running along the course of the internal jugular vein as it runs up and down the patient's neck. By convention here, I like to have the probe marker towards the patient's head. Therefore, I know where it lines up on the ultrasound screen. Notice here, as the screen indicator dot is towards the left, that superior on the internal jugular vein will be located towards the left of the screen, and inferior will be located towards the right of the screen. Here's a long-axis view of an internal jugular vein. I have the probe marker going more distally or superior within the neck, so to the left is distal and to the right is proximal. Notice the internal jugular vein that appears like a tubular structure on the ultrasound screen, and we see the blood flowing here from left to right. Here's a video clip, again a long-axis configuration in a different patient, and here we see a much more distended internal jugular vein that's lying on top of the carotid artery. Notice the swirls of blood in the internal jugular vein, showing the course of the blood flow from high within the neck to the left, low within the neck here to the right. In conclusion, thanks for tuning in for part 1 of Ultrasound-Guided Central Venous Access. I hope I've been able to score the point that ultrasound is very helpful in determining the relative anatomy of the internal jugular vein and carotid artery prior to an invasive procedure.
Okay, so especially for you guys who've done CVPs before, that's why when we try internal jugulars, it's so difficult sometimes. Even though you use the same approach for every patient, but you don't hit it. It's because of that variability, all right? That's actually why I prefer the femoral, because the femoral tends to be a bit more standard. I don't know how else to. It tends to follow a more regular pattern, you know. And especially in an emergency department, I think the femoral it's a quicker access, you know, because very often you're intubating, you are doing CPR, so the neck is already crowded. There's already a lot of people around there. So the femoral is just a bit more, you know, away from the action, if I can put it that way. So that's why it's a little bit easier to use that, right? So unfortunately, I have to get through Dr. Pereira one more time. But this one is a little bit easier to watch, okay? Because this one actually shows you how to actually put it in, okay? So don't worry.
Part 2 of ultrasound-guided central venous access will look further onto the use of bedside ultrasound to make a more precise puncture attempt on the internal jugular vein during central venous cannulation. As we discussed in part 1, we first want to map out the anatomy of the internal jugular vein by orienting the probe in both short and long axis configurations to fully investigate the orientation of the vessel. We want to use a dynamic technique for real-time guidance of the needle into the vein lumen, and for this we'll need to place the probe into a sterile sheath barrier to observe sterile precautions during the puncture attempt. Here's the needle coming in underneath the probe in a short axis configuration. Notice that the sheath needle is coming in underneath the probe at a 45-degree angle. And notice that we're using the sheath needle to first determine the location of the internal jugular vein by the ring-down artifact. We would use the same approach for the cannulating needle coming in underneath the probe at a 45-degree angle. As we discussed prior, the probe should be oriented in a side-to-side orientation with the marker down towards our left as we stand at the head of the bed, so it orients directly to the screen indicator dot, which will be oriented towards the left of the ultrasound screen. Here we're localizing the internal jugular vein using this short axis configuration. We're coming in underneath the probe with the sheath needle at that 45-degree plane, pushing in underneath, and notice the ring down artifact coming in directly on top of that internal jugular vein, telling us this is the correct puncture point. This video clip shows why a short axis orientation is an excellent starting point for cannulation of an internal jugular vein. Here we see the echogenic tip of the needle coming down and permeating the anterior wall of the vessel, and we then note the echogenic tip of the needle squarely inside the lumen of the vessel. And we can see how using the short axis orientation can guide us in a side-to-side orientation on the patient's neck in terms of lateral needle orientation with regard to the surface down to the vessel lumen. When using the short axis orientation, it's important to remember the effect of probe slice on visualization of the needle tip. Here we see the probe position 1 proximally along the needle shaft. And note in the schematic view towards the left, we see the needle with the tip squarely inside the venous lumen. However, the ultrasound probe is positioned more proximally along the shaft of the needle, and thus on the ultrasound view to the right, all we visualize is the needle above the vessel, even though the needle tip is squarely right within the vessel lumen. So we get a false determination of the tip of the needle. In order to accurately determine the location of the needle tip, we need to move the probe more distally as we advance the needle into the patient's neck along the course of the vessel. Here we see the probe positioned more distally, now in plane with the needle tip in the schematic view towards the left. And there we can see we can get an accurate determination of the location of the needle tip with regard to the venous lumen. We see the ultrasound view towards the right, and now we'll be able to see the echogenic tip of the needle accurately positioned within the vessel lumen. A second pitfall that must be avoided when cannulating the internal jugular vein under ultrasound guidance is to make sure that the needle tip does not angle to the side of the vein during a cannulation attempt. Even though we know the orientation of the vessel with regard to the skin, if we don't orient the cannulating needle along the course of the vessel, it can veer to the side of the vessel as shown in trajectories 1 and 2 here. Now, if we know the course of the vessel, we can accurately position the needle so that it goes along the course of the vessel following trajectory 3 into the venous lumen. The solution to avoiding this pitfall is to know the course of the vessel as it runs up and down the neck. We can do this in two ways. The first of which is to mark 2 points on the vessel using the short axis configuration. The needle would then enter at that distal mark and aim towards the proximal mark, passing along the course of the internal jugular vein. We can effectively do the same thing by passing the probe in the long axis configuration and knowing how the needle should pass from the top of the neck down towards the chest. Here we use a simulation model to show the correct approach for a short axis cannulation of the internal jugular vein. Notice here we have the probe in a side-to-side or short axis orientation and the needle coming in at a 45-degree angle underneath the probe. Now remember that we must move the probe distally to stay in plane with the needle tip as we advance it underneath the skin and into the internal jugular vein. And as we do that, we notice that we've successfully cannulated the internal jugular vein as shown by the red flow of blood. And here we see a side orientation of the needle with regard to the probe. Here's an actual cannulation of an internal jugular vein. Notice that we see the deflection of the anterior wall of the vessel as the needle pushes down on that wall, followed by the appearance of the echogenic tip of the needle within the lumen of the vessel. So let's watch that again. Notice the deflection or pushing down of that anterior wall, and then as the needle permeates that anterior wall, we see the appearance of the echogenic tip of the needle within the vessel. Here's a different patient receiving a central line, and notice in this clip we actually can visualize the echogenic needle coming from the surface and going all the way down through that anterior wall of the internal jugular vein to park directly into the lumen of the vessel. This video sequence shows cannulation of the internal jugular vein using the long axis trajectory. Notice we swiveled the probe into the long axis orientation along the course of the internal jugular vein as it runs up and down the patient's neck. By convention, again, the probe marker should be oriented towards distally or towards us as we stand at the head of the bed. Notice the cannulating needle will come in at a 45-degree angle under the distal aspect of the probe. Remembering that the distal aspect of the probe or the marker will orient towards the left of the ultrasound screen, we can then know to look towards the left of the screen for the cannulating needle coming down to the vessel. Here we're performing cannulation of the internal jugular vein on a simulation model. Notice here the probe is oriented along the longitudinal or long axis course of the internal jugular vein with the marker dot distal or towards the patient's head. Here we see the needle coming in at a 45-degree angle underneath the distal aspect of the probe. This will allow us to see the entire aspect of the needle as it travels down from the surface all the way down to the venous lumen and cannulates the internal jugular vein. Here we see the long axis approach and the needle coming in from left to right, and we note here how the long axis orientation is excellent for seeing vertical needle depth. Note the needle coming through the anterior wall of the vessel, and now the needle tip squarely within the vessel lumen. Here we can see how the long axis orientation allows us to plan the optimal depth for the needle tip with regard to the venous lumen to squarely secure a cannulation attempt. Now this is in difference to the short axis orientation, which was better for lateral needle orientation with regard to the vessel lumen. So using a combination of short and long axis orientations will allow you to see both lateral and vertical needle orientations with regard to the vessel lumen. Here's a video clip in the long axis configuration emphasizing the fact that the long axis view is great for determining the needle depth. And here we see a needle coming in from left to right, and notice that we can visualize the needle tip smack within the vessel lumen. Here's another long axis clip of a patient who's receiving a central venous catheter, and we see the catheter coming in from left to right. Notice here the needle tip deflects the anterior wall of the vessel, pushing it down so that it almost meets the posterior wall. Thus, the needle could easily pass through both walls of the vessel. Using the long axis technique, one can best adjust the needle tip depth and avoid puncturing the back wall of the vessel. Here's another great use of the long axis technique. Again, we're confirming that the needle tip is located within the vessel lumen, and now we can watch as the guide wire passes through the tip of the needle and moves down inferiorly down the patient's internal jugular vein. This is a great way of confirming that the guide wire is safely parked within the lumen of the vessel before threading the catheter. Let's end this module with a possible pitfall that can be avoided by first looking with ultrasound. Here we have a patient who's had a prior central line, and we notice a thrombosed internal jugular vein with echogenic material on top of the carotid artery. When we push down with the probe, the internal jugular vein failed to compress. In this patient, it would be best to look for an alternative area for puncture of a central line.
Okay, so I also fall asleep during his videos, don't worry. But it gives you a lot of information. All right, so this is the type of thing, go back, watch it again. You know, you'll pick up a little bit every time that you watch it. But basically what they're trying to say is that the ultrasound makes your life easier. The most important thing is try and find the vein. Follow the needle into the vein. So all that we are talking about, move proximal to this to make sure, put long axis, no, just make sure you get blood in your syringe. If you have blood in your syringe, you have entered into the vein. Now, if you're passing your guide wire or you find that there's some resistance, then you go again with your probe and see, now, did I go too far? Did I pull back a little bit? You get what I mean, things like that. But generally in an emergency setting, you don't have that luxury. You just got a few minutes to try and get this thing. And so it can shorten a lot of the time. All right. So, but it's wonderful when you do it because you see all of those things, except for that echogenic tip that they were talking about. The needles that we have in South Africa don't have an echogenic tip. So all that you see is just the movement of the flesh. You see that, and then you get blood coming back into your syringe. Okay. So
a linear array transducer with a venous exam.
This is a very short one. Don't get worried. Okay, it just shows you how you do it on the femoral artery. Okay. Trust me, even I'm tired of watching the videos.
Type is used to perform an ultrasound-guided insertion of a femoral vein catheter via a transverse approach. The patient is in a supine position with the operator at the right side. The transducer is placed transversely just inferior to the inguinal crease, with the orientation marker directed to the patient's right at a 9 o'clock position. The superficial femoral artery is seen as a dark, anechoic, pulsatile circular structure in the mid-portion of the ultrasound image. Deeper and slightly to the right of the image, the femoral vein will appear as a dark, anechoic elliptical shape that is compressible with transducer pressure. Adjust the transducer so it is centered over the femoral vein, medial to the artery. Follow the needle entry by slowly sliding the transducer in the direction of needle advancement. The needle will appear as a small bright dot. When the needle tip appears, the transducer should be advanced a short distance distally to follow the tip of the needle trajectory. The needle is slowly advanced under direct ultrasound visualization until the tip is seen to indent and then puncture the femoral vein. The transducer should be moved slightly, proximally, and distally to confirm that the needle tip lies in the mid-portion of the femoral vein.
Yes, I told you that one. It's a lot longer than I remember when I was drawing it up. Sorry, I told you it would be a short one. So the subclavian, if you ever decide to do, it's not really done on the ultrasound guidance, but just so that you know more or less what to do. So the subclavian is exactly what it says. It's below the clavicle. So what you do is that you actually aim, and you can feel it on yourself as well, just where the clavicle changes direction. All right, that third, that's what you're looking for. So you're looking at that area. And then you're trying to aim towards the sternal notch, and you're expecting your subclavian vein to be below the clavicle. So you kind of use the clavicle almost like how you would use a tourniquet and a dilated vein. You kind of use the clavicle as that, but don't try and get into the clavicle, please. I'm still trying to get below. But I must be honest, I don't like the subclavian approach. It has the most amount of potentially harmful complications. pneumothorax, air embolus, loss of the guide. There's so much that can happen. So internal jugular, femoral, much better. But if you decide you want to do a subclavian, by all means do it. The one advantage that the subclavian has is that it is better for central venous pressure monitoring. It definitely is the best as far as that goes. And if you want to put transvenous pacemakers, which we had spoken about in the past, all right? But if you're not using it for that, it's no use putting your patient in all of that risk. And they are difficult. They're not easy. As much as we may think they are easy, they actually can be quite difficult, right? There's a lot that has to do with setting up your patient and things like that. So that's just a basic intro. But the truth is that until you actually do it on a patient, it's quite difficult. Now, there's one thing that an intern told me a long time ago that I still keep in my mind, is that sterility is a state of mind. If you believe it's sterile, it will be sterile. That is true in a way, but we've got to try and keep things as sterile as possible, right? So in our setting, the one thing that we didn't see on those was, when, you know, all these guys who are giving us all these videos, now their ultrasound machines are actually sterilized in between usages, or they have sterile sleeves that they put over. It's done in a day theater and things like that, which we don't have the luxury of doing. So the question is, what can you do to at least try and make it as sterile as possible? Because we put our probe on everybody and we put it everywhere. So the one thing that you can do, and what I found helps for our patients, put a condom over the probe. You can put your gel in between the probe and the condom. So you put your gel on first and put a condom, or you can put it on top of the condom. It's just that the condom bubble sometimes makes that a bit difficult. So it's not 100% sterile, but it creates a little bit of a barrier and a little bit of protection. And you try and keep the area as clean as possible. All right, that's about it. And that probe head is huge. So trust me, and the condoms are even bigger. So it goes in, don't stress. You know, initially when you put it, it's like, how is it will fit? I promise, do not worry. And we've used it quite a bit. Okay, so that's another piece of advice I can give you. The biggest thing I can tell you about CVP insertion is when you put in your guide wire, if you get resistance, stop. You are not in the right place. Okay, that I can tell you, regardless of whether you ultrasound, you haven't used ultrasound. Over the years, that's the one thing that I've learned. If there is resistance, stop. Take out the guide wire, go again, because I promise you're going to waste 10 to 15 minutes trying to shove a port into somewhere that it's not supposed to be. And then you still got to go back and start all over again because the drip's not running, you can't aspirate blood, you can't do anything. All right. So when that guide wire goes, it must be a nice, smooth movement. Now, in saying that, if you use the femoral, there are sometimes valves. So when you are going, you may hit a valve, but that comes a bit later on. So in other words, you've gone through and you have a bit of resistance, but it still carries on. But what I'm talking about is as soon as you try and enter, there's just resistance. You've got to force that thing to go through. You're not in the right place. Okay, that's when you use your ultrasound probe again. You try and check where everything is. Any questions? Any concerns? Any worries? CVPs are a physical skill, like suturing. You can't watch videos and expect to know how to do them. You have to be able to do them. But like anything, they're not actually that scary. It's just a fancy drill. That's all. When you're approaching your first one, to just remember, this is just a fancy drill. I've put up drips. The only difference is that I'm putting a wire in first, I'm putting a dilator, and then I'm putting my drip. That's all, which you can even practice on peripheral veins. Your patients will get worried. All right? Treat on an unconscious patient if you want. But technically speaking, you can't do it. Right? But you get what I mean. It's just a fancy drill. That's all. Do not let it scare you. It scares a lot of juniors. CVP, you know. I didn't go to med school for long enough to do it. It's easy. It's simple. The most important, this is not a CVP teaching session per se, but when we have an opportunity to do CVPs, you guys must get in on it, see how it's done, because it is a physical skill. You need to physically know how to do it. Okay, and the more you do, the easier it gets, trust me. But in saying that, sometimes the easier it gets, when you get a difficult one, then you get frustrated because why is it not going in? I've done thousands of these. And we've all made mistakes in CVPs. I've cannulated arteries, caused problems. It happens to everybody. Don't get yourself down. As long as you're not doing it every time, then you'll be fine. Okay. So if there's no questions, then we'll end it over here. We'll post the video up later. And then, I hope everybody enjoyed it. And this Friday, there's no lecture because I won't be around, but we'll start next week again with ECGs. Okay. All right. Bye-bye. All right. No problem.